Welcome back to the Neuro Wellness Podcast. This is your host, Dr. Joe, and we have another great episode for you today. Today, we are interviewing Dr. Andrew Brodyn of Landmark Family Chiropractic, and we're discussing how to use reflexes or how to leverage reflexes for the treatment of POTS and dysautonomia. So, really fascinating topic today that we haven't necessarily gone specifically into on this show before. So I think a lot of you are going to get a lot out of what Dr. Andrew Brodyn has to say today. He is a wealth of knowledge in the world of brain rehab, especially in the world of POTS treatment. So after a quick announcement from our sponsor, we'll get right into it with leveraging reflexes for POTS treatment. This podcast is brought to you by Delta Neurohealth, located in Columbus, Ohio, where non-invasive, personalized care is revolutionizing the way we approach complex neurological issues. With cutting-edge techniques in functional neurology, functional medicine, and chiropractic care, we're leading the way in managing conditions like concussion, dizziness, brain fog, anxiety, POTS, attention, and more. To learn more, visit our website at deltaneurohealth.com. Hey everyone, welcome back to the show. This show is Dr. Joe, and today we are joined by Dr. Andrew Brodyn of Landmark Family Chiropractic. Thank you for joining us today.
Thank you for having me.
And we are going to talk about something pretty interesting. We love to talk about POTS on this podcast, and today the episode is leveraging reflexes to help with POTS. So I'm really excited what it is we're going to talk about today. Before we dive too deeply into that, though, I would love to hear a little bit more about your personal story and why you got interested in the treatment of POTS and functional neurology.
So I was in a pretty bad cycling accident when I was 25. I used to competitively cycle. I'd been training for a race. Went out on a windy day in March or whatnot, and unfortunately or fortunately, a tree fell from the side of the road and landed on my head. So I ended up with a pretty significant head injury as a result of that, and then ended up going through a kind of a long winding treatment process, going through PT and regular medical routes, and it wasn't until stumbling onto some aspects of functional neurology that was the thing that actually brought me out of pain and got me moving in the direction of getting a little bit better. So the I remember the first time I'd been in pain for about 2 years at this point, breathing, standing up tall, all those types of things. And I remember somebody had asked me to move my eyes a certain way. And I was like, yeah, okay, I'll give it a try. I've tried everything else. Why not? And they had me move my eyes a certain way. And all of a sudden, I could stand up a little bit taller and my back didn't hurt quite as much. And the light bulbs went off in my head. And I said, there's something really amazing here. Let's go digging. So about that happened, I would say, about 15 years ago now. So it's been a big deep dive for me, looking at how neurology works and how you can leverage all these things in terms of healing and getting better. And it's, at first, I want to say it was a little bit of a selfish endeavor. I looked at all those things in terms of myself, trying to make myself feel a little bit better, and in a positive way, it turned out to be a pretty amazing career, and I've met a lot of really good people and been able to help a bunch of people. So I'm excited about that.
Yeah, now you're a walking testimonial, and you can share your story and share your talents now. So that's amazing.
Yeah, thank you.
So how did you get interested in the treatment of POTS then? How does that relate?
So for myself, I had a little bit. It went undiagnosed for a long period of time. I'm speculating, but I remember that early on after my own injury, I would get woken up storm outside, rain, thunder, things like that. And I would wake up with my heart rate in the high 180s, high 190s. I would shoot right out of bed. And that happened early on. And then it started to transition and almost degrade into changes of position, random eye movements, random head movements would trigger that type of tachycardia in myself. And so it was scary. I mean, you don't know what's happening. And I didn't really have a whole lot of resources in terms of clinicians at that point to point me in the right direction. So I went the normal route. People wanted to try certain medications. People asked me to do PT and things like that. And it slowly, the more I started to work on my own vestibular system, I had quite a bit of dizziness at the time. All of those symptoms started to go away. And so that was another good segue for some of the things that we'll talk about today, is why that vestibular system is super important in the treatment of POTS and what it has to do with high heart rates and things like that. So it was it's pretty interesting. So it's helpful clinically whenever I see people that are going through something similar, because it gives me a little light bulb that goes off to say, hey, we probably need to look at this area and that area and take a deeper dive and understand those things a bit better.
Right. And that is a perfect segue for what we are about to talk about, which is great. So you do relate your the POTS you were experiencing, the tachycardia, to your concussion, right?
I do.
Yeah, definitely. And that's a similar story to me as well. I developed what I now consider POTS, looking back on it, and
Right.
after a concussion, just kind of developed, and having syncope episodes, tachycardia, all that stuff. So yeah, and it took something like learning about functional neurology to kind of help
Unwind.
finally. But now here you are, here I am. We're talking to each other and we're talking to everybody about it. So
I love it. I love it. Yeah, I think in terms of, I mean, we talk about POTS and we know there are various different mechanisms for that, right? We can have that happen via head injury. We can see it post-virally. We can see it through other means or whatnot. But a lot of the symptoms remain the same. People have elevated heart rates. They have changes in blood pressure. They experience symptoms of head pressure, fatigue, brain fog, dizziness, lightheadedness, pre-syncope, like you said. And it's interesting because there's all of those things are, I think, very intimately related, right? When I think about POTS in general, typically you think of the heart, right? Because that's the symptomatology you feel. You feel that heart racing or you feel that blood pressure. So I think the immediate response is to go and get those things checked out. And I think that's important too. I mean, there can be cardiac issues that are going on that need to be resolved first, but in a lot of cases that I've seen, the people have gone down that route and they find that the organ itself is healthy, right? It's doing okay. So for me, the way I think about it is POTS being a problem of bringing blood back up to the head. So you have some type of insult that happens, whether it be head injury or viral or whatnot. And there are changes in that neurology that happen kind of behind the scenes. And all of a sudden we have a difficulty bringing blood back up to the head. And so we have a number of different ways that we can leverage our autonomics in order to try and make that happen. So we can elevate our heart rate, we can elevate blood pressure, we can have changes in respiration, and those things can help us solve that problem, although not ideally, right? So once we start looking at that, we can start understanding that this is more compensatory versus pathological, if I can say that.
Right.
And so my question is, what happened as we zoom out in that neurology that has caused us to need to compensate that way? So if we take a big zoom out, we'll find that blood flow and basically moving resources around that body is a sensory experience, right? So we normally don't think of those things, but if I'm laying down and I go to sit up, there are other systems in my body, mainly proprioception, my inner ear, other sensory feedback that gives my brain the the knowledge that I'm changing position. And via that sensory experience, I'm then able to more adequately move blood around the system and ideally get it to the place where it needs to go. So in our exam, we take a pretty deep dive into that sensory system to try to understand which parts work, which parts don't, and what tools do we have in that system to try and leverage certain things to make sure that that happens a little bit more appropriately.
Yeah. I'm reminded the way you were talking about how the breathing or blood pressure, or they try to compensate for one another. I was reminded of the old Jurassic Park quote, "Life finds a way." Well, the brain
Yeah,
also finds a way.
I like that.
May not be under the most ideal of conditions, or may not be the most efficient way that the brain and body were designed,
Mhm.
but it's gonna find a way to survive, right?
Yeah.
Right. So, like you were saying, so with so you started talking about the different sensory inputs that play into the autonomic nervous system. So I
Mhm.
guess first off, can we talk about why those are so important and how they're connected?
Yes. Uh, that deep question. I like it. The if we take a zoom out in POTS overall, we want to think about the mechanism by which we make those predictions to raise or decrease our heart rate, right? So every one of us has a carotid artery on either side. Within that carotid artery exists a baroreceptor, which senses changes in pressure within the vessel. That information is then transmitted via cranial nerve 9 to an area called the NTS, or the nucleus tractus solitarius. So a portion of our parasympathetic nervous system. Um, I find that particular structure to be of huge clinical importance because it is a integrating center for a lot of sensory things. So if I, let's say, want to decrease heart rate, that NTS is going to take in some sensory information. It's going to filter it through nucleus ambiguous, through the vagus nerve, and we're going to decrease heart rate. Versus if I want to raise heart rate, we're going to take that information and we're going to go through two different areas of the medulla, through the sympathetic chain, and we're going to raise that heart rate. So it's important to understand what happens in terms of heart rate with posture, and we want to examine each one of those places, right? We have the artery, we want to take a listen to it. We want to do a cranial nerve exam, we want to understand how that glossopharyngeal nerve works or how that vagus nerve works, and it can give us clues as to which branch of that doesn't work. Can I not lower heart rate appropriately, or am I having trouble elsewhere? And zooming back to that NTS, it's an integrating center. So it takes in information from arterial baroreception, so pressure within the vessel, chemoreception, chemistry in the system. It's going to be a relay for smell and taste, which I find kind of interesting in the post-COVID era, that
Mhm.
people lose those types of things, and then we see a lot of POTS
That's true.
afterwards.
Yeah.
So I think we have, the way I view it is, we have a lack of integrity of sensory information that goes into that integrating center, and then the prediction that comes out of that center is inappropriate, and so we end up with elevated or decreased heart rate or other changes in autonomics. But that NTS is also an integrating center for vestibular information and visual information. So all of those things are sensory in their origin. So we think about itemizing all those things and saying which one of these things work, where might we be getting aberrant information, and how does that relate to the overall tachycardia or pressure changes that we're seeing in that person. The two systems that I spend a lot of time with are vestibular, and actually the trigeminal nerve system.
Mhm.
Both of them are they're easy to access therapeutically, and there are a lot of reflexes associated to those things that we can apply in very specific ways to help people feel better as they change position.
Great. So for listeners who may be, you're speaking Greek a little bit
Mhm.
with
Sure.
the vestibular system and trigeminal system.
Mhm.
For someone who those words and concepts are new,
Mhm.
what are those things if we could just describe them and name them? And then we can dive in a little deeper onto like how those do affect the autonomic nervous system.
Perfect. Yeah. Well, the vestibular system is basically the inner ear balance system. So we have three semicircular canals on either side that help us sense rotation of the head and its position in relation to the shoulders. It allows us to understand which way is up and which way we're going. So super important. We have two other organs in there that also help us sense translation or acceleration forward and back in this horizontal plane, and vertical, as if you were jumping up and down on a trampoline. And the trigeminal system is basically the nerve that covers the face, that gives us sensation of the face, and gives us our chewing muscles. So each of those things, interestingly, give our brain a map of where our head is. So the inner ear tells us where we are in relation to the ground, and where we are in relation to our shoulders and in space. And then the trigeminal nerve gives us an idea of what it all feels like. So in terms of autonomics, I it may be oversimplified, but without a clear target, it's very hard to aim. And so my perspective is that if our nervous system has an or an unclear idea of where our head is, it becomes very hard to move resources around that system, including blood, in and get it there accurately. So we look at those things quite a bit.
That makes a lot of sense, and you explained that perfectly.
Great.
Um, so now you can start to gather an idea of why those things are so important. Like we're talking about POTS, right? So the prevailing symptom is that tachycardia.
Mhm.
So, and now we're talking about facial sensation and where we are in space. It's like, okay, well, how does that connect? But I think you did it perfectly there. And that resource transfer and knowing where your head is in space, knowing where your body is in space in order to directly, like you said, aim those resources where they need to go.
Exactly. And the interesting part is that the inner ear and the neurons associated with it, and also the trigeminal system and that sensation of the face, send that information to an area called the rostroventrolateral medulla. So lower portion of the brainstem, really important, because that's the portion that houses our ability to change blood vessel diameter. So if we have, again, inappropriate information that filters in there, we may have an inappropriate ability to open and close those blood vessels up into the head, down in the limbs, and things like that. And we'll see those types of things in POTS patients, like the symptoms we described before, where we'll see things like venous pooling, where blood ends up in the lower extremity, and we just have a hard time moving them around. So the I like to think of that area as kind of our overall control center of how those vessels operate, and then zoom out a little bit more and say, what things influence that, and can we do a little bit better to see if we can get them to work a little bit better.
Mm-hmm. And knowing the importance of these systems and the integration of these systems.
Mhm.
Typically, POTS patients, the way you get tested for POTS is, you have the tilt table test.
Mhm.
But knowing what we were talking about just now, what are some other maybe functionally relevant tests that we ought to be doing to more in-depthly test POTS patients?
I tend to, in our practice, we tend to do a pretty extensive cranial nerve exam.
Mhm.
So really looking at how that brainstem operates. So as we go through those tests, we get an idea of all the things that work and all the things that don't. Um, and there's two ways to think about that portion too. Typically, clinically, we're looking out for all the things that are wrong, but there's value in understanding all the things that are still very much intact and working well. Um, Professor Carrick had made a statement at one point. It said that we can't use broken systems to rehabilitate a system. So the the things that still work well are our entry point and our access point to the things that work well for this patient that we might be able to use therapeutically to help that nervous system change. So in terms of facial sensation, there are a number of reflexes associated with that trigeminal nerve that help us open and close blood vessels. If I have a poor map of my face, or I don't feel certain things on that face, it's important for me to try and rehabilitate that portion first before I try and use those associated reflexes, because most likely they're not going to work the way we intend them to. So we'll do a cranial nerve exam, and aside from the cranial nerves themselves, where those cranial nerves enter the brainstem, it starts to give us an indication of that midbrain pons medulla area, and we can start gathering information about which portions of that brainstem work very, very well and which ones don't. We'll do coordination testing. We'll do some neurovisual testing. We'll look at autonomics, probably differently than other folks might. We'll look at them in a lying position. We'll look at things like heart rate and blood pressure. We'll also look at what happens when they go to stand up. So one of the things that we'll do is we'll put a pulse ox on someone, or we'll put a blood pressure cuff on someone, and we'll have them go from lying to upright, and we'll measure those responses every minute for about 10 minutes. And so for me, it's really important to understand what the trend is. I want to understand how this body has learned to compensate for that change in blood flow to the head. Do we have an elevation of heart rate? Do we have an associated elevation or decrease in blood pressure, and to what degree? And at what point do we start to feel symptoms, and at what point does this body start to recover? So once we can understand each kind of the nuance of how that particular patient is responding, we can start understanding a little bit better as to what we might need to do in what position and whatnot. Right. I think the tilt test can be, obviously, it's confirmatory to a POTS diagnosis. We know people don't feel well in that tilt. I like to put people on a tilt table as well in the office, and what we may do is we may also take them through several degrees of tilt at a time. So from the tilt table, really what we gather is that, yes, this is happening, but it really doesn't tell me at what point. Right? There's somebody lying down versus somebody sitting. There's a 90-degree change there. So at what degree do we first begin feeling symptoms? So we take them through 5 degrees of tilt at a time or so, and then measure that heart rate and that blood pressure. And I will usually stop at the first point at which symptoms begin. Let's say it's 10, 15 degrees of tilt, and that's where my therapy begins. We'll try to get those things working a little bit better, bring them back down, take them back through it, see how well they do. If we need to intervene again, we will. And then as we start to rehabilitate that degree, we may take them to the next one, if there is another one, and rehabilitate them as they go. The odd part that I've noticed doing that is that the autonomic compensation of heart rate and blood pressure can change in different positions. And that threw me for a loop. I thought it would all be uniform from lying to upright, but as we go, we'll find that heart rates can come up, heart rates can come down, and the way that autonomic nervous solves that problem, it's not always the same. So we may have to do different things and different therapies in those positions to see how we can get somebody from lying to upright.
Yeah. And what do some of these, so our title is leveraging reflexes, right? We've talked a lot about trigeminal and vestibular, and what you're saying makes a lot of sense. We're finding where the patient struggles, and that's where we start our therapy. That's where they need the help. So how can we then leverage reflexes as treatment for the autonomic nervous system? What does that look like?
Yeah, there are, I think of the sensory system, right? We think of the vestibular system or the trigeminal system. And then we think about, when we stimulate those systems, what is the overall effect on blood vessels? And both have profound effects on how blood vessels operate. So the way we were talking before is that moving blood flow around is more of a sensory experience. So those sensory systems help to communicate how I move blood around. In terms of the vestibular system, as we're lying down and we tilt our head up into this bit of neck flexion, we can trigger what's called a vestibulosympathetic reflex. So what it does is it squeezes the arteries in the legs and it helps us to move blood back up. And it's elegant the way it's designed, because we typically tilt our head up when we go to sit, and that stimulation helps to trigger let's say a better predictive capability of where I'm going. And it helps me to start engaging certain things to help move blood back up to the head. So in terms of vestibular, that's a big one. And what we may do is, again, we'll measure autonomics, we'll measure all those things, and we may use head up tilt or whatnot repetitively to try and trigger that reflex prior to changing position, to try and prime the area to constrict the way we need to before we go ahead and have somebody sit up. The trigeminal system is even more intricate. So there are 4 different reflexes associated with that trigeminal nerve, and each of them have a different response on how blood vessels open and how blood vessels close, both in the head and in the extremities. One of I think the easiest one for people to understand would be the diving reflex. And that's cold stimulation of that nerve. So I think most people in their life have had an ice cream headache at some point. And basically what happens is as you cool that nerve, it sends a signal back to the brain, said, hey, I don't like this. I like my cushy 98.6 degree environment. And we end up dilating blood vessels to the head. And we experience that as an ice cream headache, right? If we know that cold stimulation has a vasodilatory effect to the head, we can use that as something that we do therapeutically, whether applying to the face or inside the mouth, to try and create an environment where the brain starts to regain blood flow where it's lost it. And so we have the diving reflex, and it has an increase in arterial pressure. It has a decrease in overall heart rate, and it triggers an increase in constriction of blood vessels in the extremities. So again, as we're looking at that person, how they compensate, what happens to those values, whether that heart rate comes up or comes down, allows us to choose specific reflexes to try and counteract and bring people back to more of a normal baseline. So 2 or 3 of the other reflexes, one is oculocardiac, and that's direct pressure to the eyeball itself. It's going to decrease arterial pressure, it's going to decrease heart rate, and it's going to decrease how much we squeeze our peripheral blood vessels. We have the trigeminal cardiac reflex, which is direct stimulation of that trigeminal nerve. We're going to see a decrease in pressure, decrease in heart rate, again, decrease in squeeze. And then lastly, we have the nasopharyngeal reflex, which is kind of neat. It doesn't have an effect on arterial pressure. It lowers heart rate and it increases the squeeze. So that's another one that's really easy to use. For certain people, what we might have them do is take Q-tips, dip them in water and freeze them, and then have them put them in their nostrils. It looks silly, but what we end up having is that sort of decrease in overall heart rate, that increase in squeeze from the periphery, and we can have them create an environment where the reflexes are helping them change position without having the normal or abnormal responses that they're currently experiencing. So it's an interesting way of thinking about it. But it's pretty exciting when you see those changes in people.
Yeah, and that's probably something that the people comment on the most, is how kind of silly they feel or silly they look with some of the exercises, but it's all helpful. So And it's very clever and it's creative, and as you're describing it, it's like, okay, that's why we do it. That's why it
That's
makes
why it
sense.
matters. Yeah.
Yeah, exactly. Um, no, that's fantastic. And then do these reflexes, are they do they ever attenuate? Do they ever lose their effectiveness? Do you feel like you have to switch up the different reflexes that you need to leverage?
I do. I do. I feel like, again, we talked about what happens at different degrees of tilt and how that body responds. So a lot of times I will choose a certain reflex to give us more normal values, right? If we have heart rate spiking up too high and we have blood pooling, I might do things that are going to decrease that heart rate in that moment and are going to help us squeeze those vessels in the legs to help move blood back up. And that, like you said, that may change in the degree of tilt and in that process. So we have to be careful to choose the right ones. And then we also have to understand how the patient is adapting. I want to know that the theory that I have or the ideas that we have on how to help them is actually having the effect that we intend to in that moment. And so the goal for me is not really to get them reliant on those things. It's more to help their nervous system pair the appropriate response to the change in position. And so the more we practice pairing the two together, what we find is that people tend to develop a little bit of plasticity, and they develop a little bit of change, and then they're able to pair those two things together. And the responses for postural change, which is the most important part, becomes a little bit more normal, and they experience less of those types of things, less head pressure, less dizziness, less brain fog.
Yeah, and that's actually a follow-up question. So I know a lot of treatments that are out there, standard treatments, people often are recommended, the compression, stockings, salt,
Yeah.
sometimes beta blockers.
Mhm.
Uh, but what we're talking about, that stuff is not even going to get anywhere close to addressing some of these issues, right? Some of the neurophysiological issues. So,
Mhm.
so I guess those I tend to see as more of a crutch or a band-aid. They should help,
Mhm.
just day-to-day life. What we're describing sounds more therapeutic in nature. Would you agree?
Correct. Yeah. And I mean, I think both medically and functionally neurologically, we are trying to solve the same problem, right? We can have chemistry that's going to constrict blood vessels, something like mitogen, or we can have beta blockers that help reduce heart rate and things like that. Um, we're looking at the symptomatology and help bring somebody back to baseline. I think in looking at it as a neurologic problem, it allows us the ability to zoom out from the organ a little bit, and it offers us a lot more in terms of options uh, for treatment rather than just looking at it from the perspective of the organ.
Right.
Mhm.
Right. So then, under a course of care, um, I guess what should a patient be expecting along the course of care? Should they eventually expect, complete remission where they no longer need these therapies? What's the end goal?
I mean, for me, the
Mhm.
end goal is to take them away from some of the chemical management. But we have to work pretty closely with MDs in order to do that. So typically when I have somebody come in, they've already seen a number of other specialists, and they come with a quite a few different interventions that either serve them or don't. And so we have to take that into account. That's the person that comes in, and that's the solution. That's the problem we have to solve, basically. Um, I look at it in terms of reestablishing normals. And as we are able to reestablish normals through some of the functional neuro interventions, then we can have a discussion with the the doctor to say, hey, can we try reducing these things? And it acts as a good litmus test for how well we've done reestablishing normal. As you start taking away the chemical intervention, you say, how close are we to normal? How close are these people to handling this on their own? And the goal is to get them back to being better at independently managing how they move blood around their body, which is helpful. And I know in this area especially, there are a number of cardiologists that are pretty open to helping. They've also been open to helping us take somebody completely off medication for a day or two so that I can get a less interfered with clinical picture of what exactly is happening, which is incredibly helpful. Sometimes in the presence of certain drugs, what looks like something may be something else entirely. It may be masked, it may be covered up or whatnot. So that can be extremely helpful. But long story short, one of the things we try to do, again, is make people feel a little bit more, or have the ability to be more independent in how they manage those things on their own.
Mm-hmm. And I think if someone's able to reduce dependency on anything, especially chemical or whatever it might be, I think that's a huge win in people's lives.
Absolutely. And so we have varying degrees of that, depending on the root cause of why people develop that autonomic dysfunction in the first place. There are people that go into complete remission, which those feel really good. But then there are other folks with more degenerative types of dysautonomia, or whatnot, that require a little bit more finesse, and they still require some medical management. So the overall is to get them back to baseline, try to reduce the symptoms they experience, so they can go back to doing exactly what they want to do in terms of family, friends, fun.
Right.
Yeah.
And then when we consider all of these different therapeutic options that you've laid out for us, when we take 100 POTS patients, would you say that, you could come up with a reflex-based protocol for all of them that will work for all of them, or how specific do you have to be for each patient?
I don't think it's a one size fits all scenario. Every single person that I've worked with has been slightly different. Some have similarities, some don't. I think it's really important to reiterate how important that clinical exam actually is. And just because somebody has a specific diagnosis, it doesn't always mean you've gotten there the same way as the person next to you. So in certain cases, we've had issues where there's a chemical problem, right? People are abusing certain drugs and things like that, and it's inducing these types of things, and we have to handle that. In other cases, we have things like co-infection, mold, Lyme, yeast, fungal infections, things like that otherwise deprive their ability to heal or have kind of an immunologic response or whatnot. And so that's a big problem that we have to solve. In other cases, it's vestibular and trigeminal, like we talked about. In some people, it's visual. And so the goal is we understand that the brain is a integrated system, right? And it relies on a lot of input from everywhere. And the accuracy of all the information going in is going to dictate the integrity of all the information coming out. So we're going to look at all those things, and we're going to apply our tools to the patient rather than to the condition.
Right. You just have to have an underlying understanding of what's going on neurophysiologically so that you can address everyone individually, because like you said, like no POTS patient is going to be identical. Everyone's going to have their nuances and their variables that you have to address. So yeah, that
Absolutely.
yeah.
And it's difficult. it's fun. I think all of us enjoy the puzzle,
Mm-hmm.
and enjoy figuring out how it all works.
Mm-hmm.
But it keeps you on your toes, and it keeps you humble. It makes you go digging for information when you thought you had it all, and you never do. So
Yeah.
it's important to just keep an open mind and keep digging, keep looking, because every patient's going to teach you something new.
Yeah.
And they're going to teach you about some aspects that you might not have thought of before. And I think that's the exciting part for me.
Mm-hmm. Yeah, which pushes us to just become better clinicians and
Mhm.
more effective for every future patient. So, yeah.
Yeah, that's my hope.
Mhm.
Yeah.
So Dr. Brodyn, this has been fantastic so far. I know a lot of POTS patients are going to be able to mine a lot of value from this presentation.
Thank you.
Uh, but for those who are listening and really want more from you and your clinic and what you're
Mhm.
doing, how would they find out more about you?
Yeah, our website is lfcyardley yardley.com. You'll find all of our interventions, things that we treat, a little bit of information about myself and my wife, who's a big part of the practice as well. Our Instagram account again is LFC Yardley, and then we are we are always open to having a conversation. So everybody comes with different symptomatology, with different struggles and whatnot, and we're always open to having that conversation. So whether it be by phone or by email, um, we're really good about reaching back out to people once they reach out to us. And a lot of times it's just first they want to understand what we do a little bit, and then they want to understand why it's relevant to them. And I'm happy to have those discussions ahead of time, before they decide whether or not we're a good fit.
Mhm. Yep. Yep. And you guys have a great clinic. You're a fantastic clinician.
Thank you.
So I really appreciated getting to pick your brain a little bit today and
Yeah, it was
share
fun.
your knowledge with our audience. So this is great.
Cool. Thank you so much.
Of course. Well, until next time, take care.